We ended the last video by learning that the key to navigating difficult conversations in the exam room is empathy. What does this mean? How do we do this? How do we establish empathy? First, a quick review of some key concepts from the last talk. We all tend to see the world a bit differently. We think of the brain as divided between the limbic system, which is the emotional part of the brain, and the cortex, or the logical part, the newer part. We use Jonathan Haidt's analogy of the elephant and the rider. The elephant corresponds to the limbic system and the rider to the cortex. When the elephant is provoked, it is the boss. The rational brain becomes like the boss's press secretary and makes rational sounding excuses for the actions of the elephant. The elephant's motivation is to protect the sense of self and the worldview, which is developed over time. When the important beliefs of the worldview and sense of self are threatened by opposing ideas, we sense the uncomfortable feeling of cognitive dissonance. Our elephants, and hence our riders, are motivated to maintain our worldviews and our sense of self, even if it means appealing to logical fallacies or, in anger, shutting down the conversation entirely. Remember, seek first to understand, then to be understood. Okay, recall our definition of empathy. Empathy is the capacity to understand what another person is experiencing from within their frame of reference. That is the capacity to place oneself in another's position. For our purposes, we're not concerned with feeling another person's feelings. This is more in line with what we call sympathy. Most patients are not going to benefit if you feel what they're feeling, although you might feel that way. This is not productive. Most are interested in being heard accurately and without judgment. You should demonstrate that you get what they are going through. You don't even have to agree with them. For our purposes, empathy is about understanding and demonstrating that you understand without judgment. Achieving empathy can be difficult, especially in the rush setting of our medical system. It is helped along by a friendly tone. Keep conversations in a light tone that enhances both your and your patient's reasoning abilities. I'm not sure how scientific it is, but it is said that people are as much as 31% smarter when they're happy. And that makes sense. When the amygdala is not firing, the logical brain can function, well, more logically. When a clinician enters a room, they cannot help but carry any negativity that may have been generated by the conversation they just had with the last person, just moments before, and often in a room with thin walls. You have to keep your own elephant from being triggered. It is imperative that a clinician is honest. You got to do what you say you're going to do. If you tell someone that you're not going to pressure them, then don't pressure them. Follow through on promises. Also, don't pretend to agree with something that you don't agree with. This can be done non-judgmentally and with empathy. Also, part of emotional intelligence is getting a feel for where someone is emotionally in a process of change. For this, it may be useful to consider the trans-theoretic model of change. In this model, when someone hasn't considered making a change, they are considered to be pre-contemplative. We may consider someone pre-contemplative if they are conflicted as to whether they should make a change. When a person is considering making the change, but may need some help in the process, they are contemplative. This is followed by the preparation phase, which is getting ready to change. Then the action phase is when they are making the change. Finally, the change is made, and they must maintain it. This is the maintenance stage. Think about losing weight or quitting smoking or deciding to vaccinate. People in the maintenance stage are at risk for a relapse and may need to go through the stages again. An emotionally intelligent provider should have a sense for where in the process their patient is and guide the conversations accordingly. In the next talk, I will commit an academic sin and discuss a stage that I made up. This is the stage for people who reject the change that you advocate. I call this the anti-contemplative stage. In this stage, the patient's worldview and moral intuitions are challenged by your recommendations. But that is for the next talk. For now, we will focus on the contemplative through the maintenance stages. For the majority of patient encounters, Your patients will already be in the action or maintenance phase. There already will be empathy by virtue of established trust or alignment of their values with your advice. There are still a few tips that can help things go smoothly. Here's a hot tip. Research has shown that if we simply use the word because, people will be more likely to go with the flow. In this study, people were instructed to request to cut in line at a copy machine by using the word because. Excuse me, can I cut in line because I have to make copies? These requests were granted about 20% more of the time than simply asking to cut in line. For instance, next up, the 2-month vaccines because we want to protect her from infections. What questions do you have? The blood pressure is still too high. It's time to begin a medication because we want to protect your heart. Thoughts? In this talk and the next, we will draw mainly from motivational interviewing, pioneered by Stephen Rollnick and William Miller. When we consider more difficult conversations, we'll look at techniques that are designed to promote change without provoking the elephant. We'll discuss technique rebuttal, as described by Schmidt and Betsch, and a related set of techniques called street epistemology, a term coined by philosophy professor Peter Boghossian. Both this and the next talk will draw on negotiation skills refined by the Harvard Negotiation Project, as written about by attorney and project director Robert Mnookin, and by the FBI in the field of hostage negotiation, as written about by the ex-lead international hostage negotiator Chris Voss. All of these established techniques overlap and converge on key concepts. Those concepts are open questions, active listening, summarization, and of course, all of this with the goal of obtaining empathy. A goal of motivational interviewing is to guide the conversation away from sustain talk and towards change talk. When we're talking with people, we can hear them say phrases which will categorize in both change and sustain talk. For instance, an example of change talk is, I know that I should quit. And the sustain talk is, but it really helps me to relax. Another example, I want my children to be healthy is the change talk, but I am so worried about the side effects is the sustain talk. When we get used to this concept, we can't help but hearing it in our patients' conversations. Actively listen for change talk and sustain talk. The goal is to guide the conversations towards the change talk and away from sustain talk. Here's another hot tip. We must strive to avoid the writing reflex. This is the urge you get to correct someone who is in the act of saying something that you consider to be wrong. You know that feeling. You hear your conversation partner quoting something that is frankly incorrect, such as how homeopathy cures cancer. Your head starts to shake no, your heart speeds up, your elephant is getting triggered. You want to cut them off and correct them on the spot with correct information. It is almost irresistible. Don't do it. This requires a great deal of discipline. Something else to avoid is the word but. But is a negating word. But alerts the elephant that there may be conflict. There is a saying that everything before the but is BS. Consider a lesson learned from the world of improvisational comedy. Yes, and. Go ahead, try it next time. Next time you hear yourself saying but, replace it with and. This is less likely to trigger a negative response. Ronald Reagan was a great conversationalist. He once said, if you're explaining, you're losing. Next up, the trouble with you. The word you is tricky. We will deal with this word throughout these talks. It can sound accusatory. It can provoke the elephant. Avoid you when it can be taken as accusatory, such as, you need to eat better. You can be used when validating something positive about your conversation partner, such as, you did a really good job. An accusatory you causes cognitive dissonance. A validating you does the opposite, which is called cognitive consonance. Hot tip number 3, avoid making them the bad example. The word you can trigger their elephant. For instance, consider this. You don't exercise and you eat too much. That's why you gained weight. Here the word you puts them on the defense. Before they even hear what you're saying, their heart rate's already going up. Not to mention, they feel lectured to. Try this one. When someone doesn't exercise and they eat too much, they gain weight. This is better. It's not accusatory, and it's just making a statement. If you're like me, when I don't exercise and I eat too much, I gain weight. This may be better yet. It keeps it a little bit more personal, but again, they are not the bad example. You are the bad example. Instead of triggering a defensive posture, you might trigger a bit of empathy in them. Which brings us to hot tip number 4. It's not about you. Unless you're using yourself in a bad example, as in the previous slide, avoid talking about yourself too much. Don't make yourself the shining example of virtue when talking unless you're talking about how you overcame a similar problem. It's their appointment. These conversational techniques are tuned to keep the focus on the patient's motivations. If a patient wants to know how you or your family are doing, great. Thank them for asking and be brief. Okay, one last hot tip before we move on to motivational interviewing. The no-oriented question. We naturally go for yes-oriented questions. We ask questions that we want to hear yes as the answer. One of the FBI insights is that saying yes makes people feel like they are being manipulated, as if you, the questioner, are trying to get them to do something that they don't want to do. We feel vulnerable when we say yes. Now this goes against previous negotiation advice, such as the so-called yes ladder. For instance, do you want to be healthier? Well, yes. Do you like getting fresh air? Yes. Then you should exercise. Yes. Instead, no-oriented questions may give your conversation partner a sense of control. We tend to feel in control when we say no. Chris Voss described examples of no-oriented questions. For instance, if you want to bring up a topic that may be sensitive, instead of saying, "Is it all right if we talked about your weight?" maybe say something like, "Is it a bad idea to talk about your weight?" It seems like there's a subtle difference here. The patient may feel more comfortable denying that it is a bad idea to talk about weight. On the occasion that a patient responds, "Yes, it is a bad idea to talk about my weight," that may reveal useful information about his or her emotional state with regarding this topic. Would you be opposed to going for a colonoscopy? Would you be against learning to use no-oriented questions? One I like to use a lot is, would you be opposed to? Would you be opposed to taking a statin to lower your cholesterol and prevent a heart attack? So before we even start with motivational interviewing, we have learned to steer from change talk to sustain talk, avoid the writing reflex, avoid but in favor of yes and, avoid lecturing and explaining and monologuing, and use the no-oriented questions. Okay, this is probably the most important slide in the talk, and you may want to save it. Here are the basic conversational tools in motivational interviewing. Everyone loves acronyms, so here's a big one for you. ORS EAOA. This is a somewhat easy way to remember the tools in a basic order that they should follow. Things may not always go in this order, but for now, it's best to learn the script. O is for open-ended questions. These are questions designed to not be able to be answered with a yes or a no answer. When I was in medical school, I was told to ask open-ended questions, and I thought, oh no, that means they will just ramble on, go off on tangents, and I don't have all day. Well, that's not what anyone wants, and that is not what we mean by open-ended questions. As Mr. Voss states, these are calibrated open questions. These questions should begin with the words how, what, or perhaps when. Why is an open question, but it can be viewed as an accusatory word. For instance, why did you do that? It may provoke their elephant. The word why can and should be used in certain instances, which we'll talk about later. But for now, let's forget about the word why and stick with how and what. What are the biggest concerns today? Which can be followed up immediately by, what is it about X that causes the concern? Now, Mr. Voss's team recommends a little practice exercise that you can do with your friends or even your family. What are you passionate about, and what is it about X that makes you passionate? The goal is to get to what is motivating them. The A stands for affirmations, also called labels. Now, for most of the time, I'll refer to these as labels. It's just easier to say and easier to remember, and easier to make a verb out of. For instance, label that. Labels are statements from you to feed back to your conversation partner that you get the gist of what they are saying so far. If you feel that he or she is conveying a motivation or an emotionally important concern, then label it and see if you got it right. Affirmations, labels, should begin with the words sounds like or looks like. Some may prefer seems like or feels like. Once you become fluent in motivational interviewing, you will say these things naturally. It will seem unrehearsed. Now, of course, it's context dependent, and each clinician should find phrasing for labels that fit their style. Labels are really useful for opening up conversations when the patient is not forthcoming. Seems like there's something on your mind today. This works better than what's on your mind in these awkward situations. You can even introduce a little cold reading and make a guess. For instance, if they're looking away and acting disinterested, as many of our adolescent patients do, you can say, seems like there's something really annoying about being here today. It is okay to be wrong. You likely won't provoke the elephant much if it's phrased with a label. People love to correct you, and as long as you're genuinely curious and non-judgmental, it'll be okay. Labels can be said with a downward inflection if you really think you got it right. Seems like you've made a decision. Or with an upward inflection if it's a question when you're not sure. Seems like there's a decision? Okay, the letter R stands for reflections. These are also called mirrors, which is my preferred term. A mirror is simply feeding back a few words that your partner just said in order to emphasize that, well, number one, you're still listening, and number two, to guide the conversation by highlighting things that are important. For instance, you may want to mirror words that emphasize change talk rather than sustain talk. When first starting out in motivational interviewing, you may simply repeat the last three words that they said during a pause. Get a feel for when placing mirrors in a patient's story feels right and can guide the conversation. Now, using open questions, labels, and mirrors will seem awkward at first, as every new skill does. It will likely take a few months of using them intentionally before they become natural. These tools are like musical scales to a musician. Before becoming fluent in music, the scales must be mastered. Practice with friends and family, or even the person next to you on a plane. The S stands for summary. This is where you can gently take control of the conversation, especially if it seems like it's getting tangential. You sum up your assessment of what your patient is trying to tell you. Again, you don't have to get it right as long as you're non-judgmental and truly curious. It can begin with a so and then a pause. Pausing is important because it gives you time to think and demonstrate that you're trying to understand. Summaries can begin with a label, like it sounds like. If there is a conflict, label the conflict. Sounds like you've given this a lot of thought, and there is a conflict between what your family is telling you and what you've been reading, or something like that. Mention the sustain talk in contrast to the change talk. And don't say but, use and. It seems like it's hard to stop smoking because it's relaxing, and you recognize the value in quitting. This seems like this process will take a long time. Our office visits are short. And when motivational interviewing skills become natural, then your conversations may actually take no more time than the way most of us have been doing it, and the conversations will be much more productive because they will keep both participants calm and collaborative. Empathy works. Next hot tip. It probably belongs in the next talk, but it's important to consider when you're first learning motivational interviewing. Don't tell them how they feel. Now, I made this mistake a few times, so I'm speaking from experience, most recently with a gentleman in my office. Remember, the ultimate goal is to see their point of view. Consider this statement. Seems like you feel angry about so many conflicting messages about vaccines and safety. Sounds like you feel it is hard to know who to believe. Now, my patient didn't respond to this type of phrasing very well. His elephant got defensive. And I thought about it. And I think it's because I made the problem about how he feels rather than about his concerns. Sometimes their feelings are the concern, such as with anxiety and panic disorders. But unless this is the case, you may not want to tell them how they feel. Sounds like there are a lot of conflicting messages about vaccines and safety out there. Now this shows that you understand the concern. Sounds like it is hard to know who to believe. Remember, people have feelings, and the feelings are about the subject. And we want to keep the talk aimed at the subject, while acknowledging how they must feel about it. So don't tell them how they feel, but validate their feelings with I statements. Now, I statements go something like this. If I were in that situation, I would feel the feeling that needs validating. For instance, if I were told different things by different people, I would feel frustrated or perhaps confused. How do you know if you got it right? If you recall at the end of the last lecture, we talked about this helpful tool from Chris Voss. Many of us are happy to hear the other person say, "You're right." Now, chances are when someone said, "You're right," what they really meant was, "Please stop lecturing to me." If you hear "you're right," you may want to go back and use labels and mirrors until you hear the words, "That's right." "That's right" is directed at the statements that you made, meaning you've stated the problem as they see it from their reference frame. "That's right" means you got it right. You achieved empathy. Remember, it's okay to be wrong. If you got there through sincerity and non-judgmentally, that will not upset people. That will just make them happy to correct you. This gives you a chance to rephrase it until you hear, "That's right." This is all reflected in the Harvard Negotiation Project's empathy loop. Number 1, inquire about a subject or an issue. Number 2, the other side responds. Number 3, you demonstrate your understanding of the response. Number 4, test or check that understanding with the other person. In other words, you loop your understanding of the problem back to them. If it's not correct, go back to step 1. Seek first to understand, then to be understood. Stephen Covey. Many people cannot listen at all until they've blown off steam. Let them say their piece. Give them plenty of time. Let them run out of gas. Be prepared to show them that you understand. Robert Mnookin. Hear that? Silence. Mr. Voss calls this a dynamic pause. A good pause is more powerful than words. It gives people time to absorb information and see if it fits. Silence can sometimes be awkward. It makes us think. Pauses are for the rider, not the elephant. Logic happens in the pause. When you think you've got to a point of empathy, pause. Be silent for a few moments. Let it sink in. It's only after you've demonstrated that you understand their perspective that you are ready to challenge them a bit. E stands for evoke. Here is where you may begin to guide them to make their own changes. When we discussed open questions before, we discussed that you must be careful with the word why, or why questions, because why provokes a defensive posture. It provokes the elephant. Here is where a calibrated why question can be useful. In this case, you want them to be defensive about a position that you both share. Why do you want to be healthy? Instead of lecturing them on the benefits of good health, get them to provide reasons for being healthy, or quitting smoking, or exercising, or vaccinating, or whatever the case may be. They should be the ones to define the why, the motivation. Now that they've defended their motivation, it's time to talk about the what. What kind of changes seem reasonable? Again, most elephants don't respond well to being told what to do, at least in this paradigm. Let the rider decide what changes to make. What is nothing without how. How is about implementation. How do you see yourself making those changes? To achieve a goal, it's best to let the patient make the plan that is right for them. People are more apt to stick to a plan that they made up. No use telling people to exercise in the morning if they work nights. Let them tell you how they're going to do it. Follow that up with labels, mirrors, and a summary until they say, "That's right." If it seems like they need your help, either with specific advice or referrals or medication or whatever, then the last phase of motivational interviewing is defined by the letters AOA. Ask. Ask if you can provide help. For purposes and practices of good habits, try to make it a no-oriented question. Would you be opposed to learning more? Again, no-oriented questions are less threatening because they give a sense of control. They give the right of refusal to the patient. Apparently, there is less mental energy or cognitive dissonance needed for no answers rather than yes answers. The O is for offer. This is a straightforward offer. Put it out there non-judgmentally. Explain what you have to offer. This might be information or services like dietitians or physical therapy or prescriptions, etc. I can provide more information. I can help you with that. Lastly, A is for ask. Here you basically ask if your help is wanted. Again, for practicing, you may want to come up with a no-oriented question. Use your best judgment in the moment. Would you mind if I did that for you? This is a no-oriented question. No questions are nice here, because if the patient says no, they wouldn't mind, then you have their permission to proceed. If they say yes, they would mind, that gives you some valuable information about where they are on the trans-theoretic model of change. Perhaps they are not contemplative, perhaps they are pre-contemplative, or what I have called anti-contemplative. This last ask is where you get their consent to actually help them. The following is a mock conversation based on countless exam room conversations that I've had. I think it is a good idea to write out conversations if they went well, and especially helpful if they went badly, like the one where I told the patient how he felt instead of understanding his problem. Every PCP just loves the part of the yearly physical where you talk about exercise. Now, for those newbies, that was sarcasm. What can you tell me about your exercise effort? There's an open question. Oh, it's not as much as I should be doing. I started walking in the mornings, but work has been very busy. I have to be there at 6 a.m. I'm too tired when I get home. Sounds like you have a very hectic work schedule, and exercise is important to you. Notice the label, no buts, and use and. Yeah, I do want to exercise, but I just don't have the time. Notice change talk followed by sustain talk. You want to exercise. This is a mirror. Emphasize the change talk. Yeah, it's not like I don't want to. I'm just too busy. Your schedule seems busy. Finding the time for it is tough because you're up early and tired in the evening. Sounds like your health is important to you and you want to exercise. This is the summary. So let's see if we got it right. That's right. Empathy is achieved. Again, if not, then go back and retry. Okay, so you got it right. You've achieved some empathy. It may be time to evoke for change. Why is your health important to you? Well, I want to be around to see my kids succeed. I don't want to be a burden on them when they should be living their own lives. I want to enjoy my retirement someday. It's in this statement that we can pluck out the patient's motivation. Sounds like you have a happy vision for the future. With this affirmation label, We want to see if we got the sentiment of his motivation correct. Right, I sure hope so. There's your that's right. What kind of changes seem reasonable to help you get to these happy goals? Well, I could try harder to find some time to exercise. Maybe I could eat a little healthier. So this is the what portion. What is nothing without how, though? When would be the best time to exercise for, say, 30 minutes? I get some time at lunch to walk. I suppose I could walk then. There's the how. You could start walking at lunch. This is a mirror. Reflect back what they just said. Yeah, I could do that. Wow, okay. Sounds like you can help yourself and your family by walking for 30 minutes at lunch. Ask, offer, ask. Remember, we've been talking about diet so far. How would you feel about having some professional guidance for your efforts at eating better? Note that this is not a no-oriented question. Oh, I know what to eat. It's just a matter of doing it. Okay, now this didn't go so well. Let's try that again with a no-oriented question. Would you be opposed to having a meeting with a dietitian? I suppose it wouldn't hurt, but I don't have a lot of time. Notice the change talk followed by the sustained talk. It wouldn't hurt. There's your mirror. We have a dietitian that can work with you remotely. I would like to offer this to you. I guess so. No. Is that permission? Is that consent? Not sure. Would you mind if I sent the orders for the dietitian consult? No, I wouldn't mind. Yeah, I think that would help. There's your permission. We covered a lot of ground. When you are the guide, it takes an understanding of what motivates the elephant to avoid getting trampled. An effective guide lets the elephant feel safe. Only then can the clinician talk to the rider. Any new set of skills requires practice. It's like learning an instrument for the first time. You have to practice your scales before you can make music. You have to learn what not to do before you learn what to do. Don't correct people. The writing reflex can provoke their elephant. Don't monologue. No one likes to be lectured to. Avoid the word but. It is a negating word. Don't make it all about you. Don't tell them how they feel. Do practice these skills. Practice open-ended questions. Practice what questions, how questions. Use affirmations, labels, reflections, mirrors. Put it together in a summary and see if you got it right. Evoke for self-change. And remember, people are more accepting of your help when they give consent for it. Ask, offer, ask. Once these skills become natural, you can go off script a bit. They don't necessarily have to be in the order that we talked about. You'll really learn to get a feel for how it's going, whether or not you've achieved empathy. This talk was about keeping conversations from becoming difficult. The next talk, we're going to delve into how to handle truly difficult conversations.